Hello everyone and welcome to today's presentation, which is part of a series of webinars provided by the Division of Public Health, Section of Chronic Disease Prevention and Health Promotion. Our section's vision is for healthy and safe Alaskans, and our mission is to identify and advance the conditions that lead to safe and healthy lives. The primary aspects of our work include health promotion, chronic disease prevention, data collection, and surveillance. This webinar series was created to provide a forum where we, as public health professionals, can have an open dialogue around specific projects and explore ways to collaborate. We will be offering webinars on the third Tuesday of each month at 1 p.m. In addition to sharing our work with you, we hope these webinars will spark your interest in learning more about our projects and explore opportunities for further collaboration. To give you a sneak preview, next month we'll be discussing Alaska's indicator-based information system, which is a resource that allows you to better understand the health status of Alaskans. Another way you can stay connected to our work is through our monthly newsletters. You can sign up for the newsletter on our section's website. Our website address is at the bottom of all of our slides. There are a few housekeeping items to go over before we start. Please mute your phone. Also, please do not put this call on hold. If you receive a call, hang up and call back in. The webinar is planned for 30 minutes, a 20-minute presentation followed by 10 minutes of open dialogue. Audio for the webinar will come through your computer. Another option is to call in through the number provided here. If you have technical difficulties, please let us know by using the question function on the GoToWebinar control panel. You will need a microphone for your computer, or you will need to call into the number provided to ask a question out loud. Please hold questions until the end of the presentation. To ask a question, please raise your hand by clicking the hand button in the GoToWebinar panel. With that, I will let Janice introduce herself and to the topic of today's presentation.
Thank you, Kelly. Welcome to you all, and thanks for attending this webinar today. I'm Janice Gray, the nurse consultant for heart disease and stroke prevention in the section of chronic disease prevention and health promotion with the state of Alaska. I'm going to provide an overview of the quality improvement high blood pressure control project that we are guiding with the Alaska Primary Care Association at 6 federally qualified health centers. I'm going to review why we need high blood pressure control, provide an overview of the Quality Improvement Coaching Project with the Alaska Primary Care Association and the state of Alaska, review data from the 28 FQHCs on high blood pressure control, and provide links to resources that any clinic can use. A 29th FQHC has recently been added, but no data is available from that new site. Chronic disease prevention is the focus of our work and the focus of this project. In Alaska, heart disease is the #2 cause of death behind cancer. Chronic diseases make up most of the top causes of death in Alaska, and those are highlighted in red. High blood pressure is a major risk factor for many chronic diseases, so its control is very important for a healthy population. High blood pressure is a systolic blood pressure greater than or equal to 140 or a diastolic blood pressure greater than or equal to 90. The blood pressure goal is a systolic blood pressure less than 120 and a diastolic blood pressure less than 80. Prehypertension is defined as a systolic blood pressure of 120 to 139 or a diastolic blood pressure between 80 to 89. And those distinctions for or and are important because if one number or the other is out of the preferred range, then it's considered either high blood pressure or pre-hypertension. Hypertension is a problem or a potential problem for everyone regardless of age, race, or gender. However, you can see the huge challenge that the Black population faces with hypertension in the U.S. and Alaska, and for Alaska Natives in Alaska. The mortality rates shown here are for deaths where hypertension was a primary or a contributing cause of death. Nearly 1 in 3, or about 72 million adults in the U.S. have hypertension. Of those Americans with hypertension, about half are not yet under control. And that's defined again as systolic blood pressure less than 140 and a diastolic less than 90. 35 million adults, or about 48%, have uncontrolled hypertension. Of the approximately 35 million adults with uncontrolled hypertension, 13 million do not know that they have high blood pressure. 17 million are aware that they have high blood pressure and are being treated with medication, but are still not under control. An additional 5 million are aware of their high blood pressure, but not taking medication for it. And in those 17 million, most people with uncontrolled high blood pressure know they have high blood pressure, see their doctor, take their prescribed medications, yet are still uncontrolled. From this graph, it looks like the percentage of Alaskans with high blood pressure is increasing, but it's more likely that more people are being diagnosed. Remember that we expect about 1/3 of people to have high blood pressure, so we are nearly at that 33% average. And these data are self-reported, so these are from phone surveys and individuals stating that they have been told they have high blood pressure. With the wide scope of the problem with high blood pressure, the CDC has made high blood pressure control a priority. These are some of the strategies the CDC promotes in their work and through their funding for the states. The states choose the activities to make these things happen. These were some of the factors that led to us doing this quality improvement project. We tried to do the most good for the most people, empower caregivers to make the changes that are important to their clinics and their communities, and then use available data to measure a starting point and to know when we made progress. So why did we choose federally qualified health centers? FQHCs had the best, most specific data available to measure blood pressure control. And the FQHCs are located throughout the state, including many rural areas. This map illustrates the distribution of community health centers and hospitals throughout the state. The community health centers include the 28 and now 29 FQHCs. And there you go. So these are the goals the state of Alaska and the Primary Care Association are addressing through their coaches. We want to improve blood pressure control as measured by these specific metrics. And it's important that all of the elements match so you can compare different data sources to each other. So having the age be 18 to 85 and have the blood pressure be less than 140/90 are important metrics. And then the second thing is to create a sustainable peer network to allow ongoing collaboration between the clinics and throughout the state. Can you guys try to advance that? Okay, thanks. So what does the Quality Improvement Facilitator Coaching Project do? The project consists of hiring healthcare practice quality improvement facilitators, and that's a mouthful, to provide on-site coaching for the members in the FQHCs to improve the care of patients with high blood pressure. The coaching includes how to use the quality improvement process and offers resources on how to improve blood pressure control. These are some of the methods used to meet the project goals. We use established quality improvement practices, coach the staff to use the PDSA cycle, and that's Plan, Do, Study, Act, to successfully make small changes that lead to larger overall changes. Use the electronic health record and process data to evaluate the success of each PDSA cycle and evaluate the success of controlling high blood pressure in the clinics. And adopt best practice protocols established nationally. To kick off the project, the Alaska Primary Care Association hosted a 3-day Quality Improvement Academy for 40 FQHC staff members in June of 2015. The participants learned the quality improvement process and QI tools that were able to collaborate with other FQHC staff members. Data are important to the quality improvement process. They can direct where to focus our efforts, let us know where we are starting, if changes we are making a difference, and if we are meeting our overall goals. To do this project, we wanted to have some idea of what best practices were already being done. We wanted to make sure that the work was meaningful. These are a few of the responses from a 2013 survey of FQHCs that looked at the care of patients with hypertension. The goal is to have these best practices adopted at 100% of all clinic sites. The highlighted practices in the table, the pink ones, were what we thought at the time were good choices to focus on, and this survey was anonymous. This is what we found. FQHCs were most likely to have direct care staff trained at all sites in accurate blood pressure measurement, that was 85%, and to use a hypertension guideline, that was 76%. Sites were least likely to have a policy in place in which patients not at goal or with a new blood pressure med were seen again within 30 days. That was only 32%. For this project, we had limited resources, so we had to narrow the number of FQHCs from the 25 total at the time to 3 to 6 participants. The data elements used to choose which FQHCs to invite were the percentage of patients with high blood pressure that are in control. For that, we used the 2013 UDS data, and that's the universal data set used by the federally qualified health centers, because it was the most recent data publicly available at the time. It was available as of August 2014. We looked at the size of the population served by the clinic, and the clinic must have been using an electronic health record at the time. Once the Primary Care Association was chosen as the facilitator, the APCA staff also helped decide which clinics to invite. Because of the resources available within the Primary Care Association, we were able to include 6 sites instead of the original 3 that we had thought we would be able to do. This graph shows the number of patients seen at the FQHCs. Some of the FQHCs have 1 site and some have multiple community health centers under their umbrella, so this graph is a little misleading. The numbers here are the total patients seen in that FQHC, but the site in the cohort or the group, our first group, may be 1 community health center under an FQHC umbrella. The highlighted sites are the ones participating in the first group or cohort. So you can see that they range from very small to fairly large, except Antioch is one of the community health centers that's underneath the YKHC umbrella. These are the locations of the clinics in the first cohort. You can see that they're located in several areas of the state, and I'll just list them off: Wrangell, Antioch, Naknek, Homer, Yakutat, and Fort Yukon. These are the data used to help choose which of the FQHCs to invite to participate. The goal is to meet the 70% million hearts benchmark. The 6 FQHCs chosen had between 45% and 56% of their patients with hypertension under control. The yellow highlighted sites are in the first group. This shows the improvement in hypertension control prior to any intervention from this project. For the clinics in the cohort, this illustrates the amount of progress they made during using their resources. The cohort range went from 45 to 56% in 2013 to 53 to 93% in 2014. Again, the yellow highlighted sites are in the first cohort. During this year, Alaska added 3 more FQHC sites to make the total of 28. On this graph, I pulled out the data for the 6 cohort clinics and tracked them from 2011 to 2015. I labeled when the FQHC cohort clinics were chosen and when the interventions began. You can see that 2013 was a low year for high blood pressure control for all 6 clinics. It's too early to know if it's significant, but the trend is for all of the clinics to track toward the 70% million hearts goal or above. So what is the future of this project? Starting in July 2016, we plan to add 6 clinics, creating a second cohort. We'll continue relationships, including coaching and training, with all clinics as new cohorts are added. The Primary Care Association has begun and will continue to do on-the-road QI process trainings at the clinic sites to include all staff at that clinic for cohorts 1 and 2. We'll continue to expand the FQHC peer network and add FQHCs to new cohorts and continue QI training and coaching through June 2018, when probably the funding will end. We may be able to hold a second QI Academy training in Anchorage for FQHC staff, depending on resources available before the end of that grant period in 2018. National and international agencies are working to address high blood pressure. Here are some of the initiatives, toolkits, and protocols available to all caregivers. Million Hearts, a 5-year initiative launched in 2012 to prevent 1 million heart attacks and strokes by 2017. Hundreds of public and private sector partners signed on to focus their efforts to reduce the number of people who need treatment and improve the care for those who need it. Million Hearts chose to focus on 4 areas to make the biggest impact to prevent heart attacks and strokes, the ABCs. Appropriate aspirin use, blood pressure control, cholesterol control, and smoking cessation. This slide shows that we have a lot of room for improvement on the ABCs. For example, only half the people with hypertension have their blood pressure controlled. Only 1/3 of the people with high cholesterol have it controlled, and only 22% of the people who are trying to quit smoking get the help that they need. To achieve the goal of preventing 1 million heart attacks and strokes, Million Hearts set a 65% population-wide goal for each of the ABCs. These goals include people who do not have a usual source of care. To reach the 65% population-wide goal, it's important for clinical systems to reach a 70% target. And that's the target I've highlighted on the graphs. One way to ensure that all patients who have hypertension are treated appropriately is for each clinic to follow a protocol for routinely evaluating patients for hypertension, then intervening when needed. This is an evidence-based sample protocol developed by the Million Hearts Initiative that can be adapted for your clinics. These are the most current protocols and guidelines for treating high blood pressure and its risk factors. This year, or maybe next, a comprehensive protocol is expected from the American Heart Association and American College of Cardiology. The current protocols address aspects of hypertension control, but the last comprehensive protocol was released in 2003, the JNC7 guidelines. These are some healthcare practice toolkits. The Washington State Hypertension Control Toolkit on the left is an excellent comprehensive resource for all clinical practice teams. And it has a lot of resources within this one tool. The one on the right, Measure Up, Pressure Down, is the Million Hearts current protocol provider toolkit. The next few slides have links to resources. The slides and a recording of this webinar will be available on the Alaska Chronic Disease Prevention and Health Promotion website, so the resource links that follow are easily accessed after today, so you don't need to worry about writing them down. These are some of the resources within the state of Alaska. These are resources from national organizations. This is a list of some of the Million Hearts resources. And this is a beautiful winter day in Juneau, which is today. I want to thank you all for joining us today. And does anyone have questions?
Hey, Janice, this is Kelly again. Hey, I just want to say thank you very much for the great presentation and for sharing your project with us. And all of the information about heart disease, stroke prevention. We do have looks like a couple of questions. So Tracy Marshall, I'm going to unmute you and go ahead and ask your question. Oh, Tracy, I don't think that you have access to speak online. Perhaps you can type your question into the box provided. So we'll go with Alice Cohen next. Sorry, having a little bit of problems here. Alice, it looks like you just unraised your hand. Sorry about that. On this end, I do have a question for you, Janice. I think we're probably waiting for people to figure out how to go through these. The heart disease and stroke is one issue. Also, just I think for some of the public health practitioners out there, if somebody was interested in doing like a quality improvement project within any clinical setting or an FQHC, do you have any words of advice, lessons learned that you could share?
I think the best resource that has the longest track record is the Institute for Healthcare Improvement, and it's based out of Boston, and they have been working on how to implement best practices for probably 15 years or more. And David Berwick, who was head of CMS for a while, was the person who started that. And it's based on the PDSA cycle. So they have done a lot of work with tools, process, information that you can use to adapt to your clinic, your clinic environment. So you don't do everything that's cookie cutter from someplace else, but they have a lot of resources. So the Institute for Healthcare Improvement is my answer to that.
Thank you. I don't see any other questions coming in right now. I'll give everybody a minute. Remember, you can either raise your hand and we can unmute you, or you can type a question in. We have one in the room.
Hey Janice, this is Andrea. I have a question on this. When you surveyed the FQHCs about what practices they were currently implementing, where did you get that list of best practices from?
At the time, we did a literature search, but in the years since then, one of the resources, I'm going to see if I can click this back, the hypertension control change package for clinicians now includes all of those best practices, and it also has ideas for how to make a change for those different best practices.
That's great. So a little more of a shortcut than you had to go through.
Yes.
So I'm not seeing any other questions. Janice, any parting words?
Just thanks to everyone for coming.
Well, thank you, Janice, for doing this. It was a great presentation. Everybody should know that they will receive an email within a couple of days with a link to the recording to this and the presentation itself. So if you want to go back and find these resources, it'll be provided to you by email. Please take the survey if you have a chance after this presentation ends today, and join us next month for our next webinar. Thank you very much.